Hello, everyone, and welcome to today's webinar, Get with the Guidelines, Hemorrhagic Stroke, Setting Yourself Up for Success. My name is Sue Abelt, and I'm a program consultant for hemorrhagic stroke with the American Heart Association. Before we get started, I'd like to go over a few items so you know how to participate in today's event. This webinar is being recorded and will be sent via email within 24 hours. There are no CEs associated with this webinar, but you may access a certificate of completion in your follow-up email after the conclusion of this event. You will have an opportunity to submit text questions by typing them into the question pane of the control panel. Feel free to send your questions at any time during the presentation, and we'll collect these and address them during the Q&A session. If you do experience any technical issues during the presentation, most can be resolved by refreshing your browser. If your issue is not resolved following the refresh, please refer to the GoToWebinar customer service team, whose contact information is found in your webinar confirmation email. To view live closed captioning for this webinar, please utilize the hyperlink that's found in the chat. All right, with that, let's get started. Here is our agenda for today. We will first revisit an overview of our hemorrhagic stroke initiative, and then move into the review of two new ICH measures that were launched in August. And then we will have a nice demonstration from Kim of how to run some ICH reports, along with various tips for making the most of your ICH data. And then finally, we're thrilled to hear from three panelists as they share ICH-related quality improvement activities. All right, so our presenters today, we will hear from Kim Chapoy-Casas, who is our Senior Product Manager for Health HIT here at the American Heart Association. And then on the next slide, we can see our three model share panelists. We will hear from John Pham, who's a Senior Data Analyst from Mass General Brigham and Women's. Then we'll move on to hear from Kathy Schmidt, who's a stroke data specialist at the Hospital of University of Pennsylvania. And last but not least, we'll hear from Linda Matrich, who's a quality assurance manager at the OEM for EMS in Milwaukee. All right, just a special note here. We love that you send in all of your questions to us in the questions pane, but we may not get to all of your questions that we receive in the chat during today's webinar. So for any outstanding questions, please reach out to your American Heart Association program consultant for healthcare quality, or alternately, you can email gwtsupport@heart.org, and then those questions will be filtered to the appropriate consultant for it to be answered. So thank you for that. All right, so let's go ahead and revisit our hemorrhagic stroke initiative. So why are we focusing on ICH? As you well know, ICH accounts for approximately 10 to 15% of all strokes and carries a disproportionately high risk of early death and long-term disability. The evidence for optimal treatment of ICH has lagged behind that for ischemic stroke. So it's important that we translate the guidelines into actionable metrics for data collection that will really enhance the outcomes for our ICH patients. If you recall, next slide, Gina. If you recall in a previous presentation, our phase one of this initiative did include 20 comprehensive stroke centers from around the country that participated for 3 years, really testing our ICH measures. The success of that phase one really lent itself to the launch of phase two, which occurred at ISC in February of this year. So we put out the call to action for those hospitals who have Get With the Guidelines stroke. If they'd like to add these ICH data elements to their stroke registry, they can certainly do that. And this is a map. So to date, we have 538 hospitals who've answered that call to collect additional ICH data elements that were added to their stroke registry. So this is just a snapshot of the number of hospitals per state. So again, we are just thrilled with the outpouring response to this ask. So next slide. I put this some hyperlinks to our hemorrhagic stroke survivor stories. The American Heart Association really doesn't, not to toot our own horn, but we do a nice job really highlighting those survivor stories. And these in the hyperlinks here are all related to hemorrhagic stroke survivors. I thought this might be a nice addition to some of your multidisciplinary meetings where your focus is always data quality, process improvement, but this really lends itself to sharing the importance of why you do what you do. So feel free to use those. All right, so if you do not currently have the ICH data elements in your Get with the Guidelines stroke registry, you may do this free of charge. There's no additional fees or contracting. We just encourage you to reach out to your program consultant for healthcare quality and or use the email that you see below, and we will get you set up. All right, so let's move on to discussing the new ICH stroke measures along with review of the previous measures. So really at the foundation of all of our Get with the Guidelines programs is the promotion of consistent adherence to our scientific guidelines, obviously to improve patient outcomes. So this is just a reminder that our ICH measures are derived from both these clinical performance measures for ICH, and along with the second slide, Gino, is our 2022 ICH guidelines. So the links to these papers will be found in our resource section of this slide deck. So based on these results, based on the information from our scientific papers, these are the 16 measures that are a result of those guidelines. So we currently now have 11 performance measures or rate-based measures and 5 descriptive measures. And those highlighted in blue are the 2 new measures that were added to Get with the Guidelines stroke for ICH this past August. On the next slides, we'll just have a snapshot of our measure description, which delineates those patients who are in the denominator. And in this case, for inappropriate platelet transfusion, the goal is not to have the numerator satisfied. So as a reminder, this measure is looking at the percent of patients with ICH being treated with an antiplatelet who do not undergo surgery, who are administered a platelet transfusion within 48 hours of arrival. So as I was saying, this is an inverse measure. So a lower score results in better quality. So you do not want a patient in the numerator, as inappropriate platelet transfusion may worsen patient outcomes as outlined in the guidelines. So I know that's a lot of words, but the measure descriptions that Kim will highlight in the next demonstration really does a nice job of outlining some of the exclusions as well. And the next measure that is new as of August is our descriptive measure. So our descriptive measures is really looking at those patients who receive a platelet transfusion, but they're looking at those antithrombotics that the patient was on prior to arrival. So this report renders as a histogram and is grouped by the 4 groups that you see here on the screen. So the 1, 2, 3, and 4. So all patients on antiplatelet and so forth. So that's just informing you what your patients were on prior, what antithrombotics they were on prior to hospitalization, and if they received that platelet transfusion. So, all right, those are the 2 new measures, and certainly at any time, please feel free to type in the chat. And also, if you have any further questions after this webinar, go ahead and email your program consultant, and we can make sure that you fully understand this measure. All right, so now that you've been collecting ICH data for a few months since its launch, we thought it would be really important to navigate the reporting capabilities within Get With The Guidelines. So I'm going to turn it over to Kim to run through some demonstrations.
Thank you, Sue. So today we're going to demo a couple parts of the platform that will hopefully allow you to better utilize the ICH layer and all of the resources that are part of that layer. So first, we want to show you where you can find some resources in the library. Then we will highlight the ICH measure bundle. We'll show you how to add and remove benchmarks and display your data in various ways so you can get more out of those reports, and then also show how to drill down on missed opportunities in the ICH layer measures. So starting with the library, on the left-hand side here, you can navigate to the library. You'll see a number of resources available to you as the user. In the reports and measures section, you'll find a Get With The Guideline Stroke ICH measures hyperlink. And as you all are aware, many of these resources in the library are configured based on the form groups that your site has active. So those of you that have the ICH layer, you will see this document there. If you do not have the ICH layer, you won't see the document, but you can reach out to your local AHA QI consultant. They can share this document with you if you're interested in the layer and want to get a little bit more information about the measure descriptions. This measure description document will be really helpful when you start to drill into your data. Perhaps you have some outliers, you want to determine whether it was something in abstraction that needs to be updated or a true process improvement opportunity. These measure descriptions will be really helpful for you. Beginning, you'll see a table of contents that outlines each of the measures that are part of the ICH measure bundle. I'll go, for example, to our baseline severity score measure. You'll see a short description at the top of the document, the initial patient population that will be considered for the measure, and then you'll see the denominator criteria. So among that initial patient population, in some instances, the denominator criteria is the same as the IPP. In other instances, it's a subset of the IPP. And then below the denominator criteria, you'll see the exclusions, both the on the left-hand side, sort of layman's terms for the exclusions, and then on the right-hand side, the corresponding data elements and response options. And then further below that, if the measures do have any exceptions, which means that the patient, if they meet the numerator criteria, they will be in the numerator. If they do not, they will be taken out of the measure. So if there's any exceptions for the measure, you'll see these here. And then finally, what the numerator criteria is. And then further at the bottom, there is a rationale statement. I know this can be really helpful when you're working on some process improvement activities to share with your clinical team the rationale behind the measure. Hopefully that's helpful for you all to just have a better idea of how these measure description documents will help you in drilling into your data a little bit more.
Thank you, Kim. Really appreciate that. We thought it would be really nice to run through some real life scenarios, some requests for information that I'm sure you get on a weekly or monthly or quarterly basis, and then how to pull those reports from Get With The Guidelines. So we have 4 scenarios in total, and with each of them, you will find a step-by-step pathway for running the reports, along with Kim's demonstrations. She'll go into the tools so you can see how to actually pull these. And then please note that the following examples may be run and Get With The Guidelines, even if you don't have the ICH layer turned on. So let's take a look at the first one. So in this scenario, your stroke medical director would like a report on how patients arrived at your hospital with the final clinical diagnosis of ICH.
Thanks, Sue. I'm sure this is not an uncommon request, is to drill into your data more based on patient arrival mode. So I'll show you how to stratify that by patient's diagnosis, and we can look at this more closely just among the ICH population. So I'll select again my 2023 data, and here under descriptive measures, I'm going to run the diagnosis report. And we're going to add a filter for how patient arrived at your hospital. Something to note is in the filter section, there is a separate box to indicate you want to filter on a single select variable versus a multi-select variable. So since how patient arrived is a single select, I would search for that under the standard filters box. If it were a multi-select element, I would search for it under the multi-select box. We do have a data element crosswalk in the library, which specifies whether each element is single select or multi-select. You can also find the display labels in that data element crosswalk. That is what you search for in those data filter boxes. So I've added how patient arrived as a filter option, but I can apply it either as a filter, so filtering down for just a particular response option, or as a comparison variable. So you can look at the results across each response option for how patient arrived. So while this data is rendering, I just want to point out in the top right-hand side is your filter icon. That is where you can expand or hide the section where you have filters on and off. So first we'll see the results here of diagnosis. And I'm going to open the filter pane here. You can see if I wanted to filter by one of these response options, I could, but in this scenario, I want to show you how to apply it as a comparison variable. Now arrival mode has become the comparison variable. And so you'll see among my intracerebral hemorrhage patients, which is this group here, it groups each of the arrival modes. And you could drill into that more in your measured details and case list as well. Again, among my intracerebral hemorrhage cases, you can see each of the arrival modes. All right, so back to you.
Thanks, Kim. Our next scenario, Gino, can advance this slide? Perfect, thank you. So in this scenario, your stroke multidisciplinary team is updating your ICH specific stroke education materials for the upcoming fiscal year. The team wanted to know what past medical history was most relevant in their ICH patient population last calendar year to focus their priorities. And once again, you will see the recommended steps here in this pathway. In the slide deck, in the handout section of this webinar, you will also see step-by-step screenshots of what Kim is demonstrating in the live environment. So you will have those as reference. Thanks, Kim.
Thanks, Sue. In this example here, I'm going to run just a few months of data. So we'll do January to March of 2023. And then under descriptive measures, we'll run the medical history measure and apply a filter for a final clinical diagnosis related to stroke. You may remember in the last example, we selected a filter on the parameter page, but we applied it as a comparison variable so that across all of the response options for that element, you could see the results. In this example, we'll use final clinical diagnosis as a true filter. So we'll filter down to just include ICH patients. The visualization here may be busy because there's so many response options to medical history. So we'll, after the reports render, we'll use the measure details case list section and the table for the information that we need to get back to our team for the scenario. For my filters here, I will select ischemic stroke, I'll deselect TIA, that'll leave us with just the ICH patients. And then since I did not aggregate my data, I'll see month by month how many ICH patients there were and each of the medical history selections for those patients. You can also right click in this table and you can export this to Excel. Okay, so we'll turn it to you for another scenario.
Thanks, Kim. I really like that scenario, just to start thinking about your data in a manner that maybe you hadn't thought of before, or, you know, we have all this wonderful rich data that you collect, and it's nice to see how we can pull that out and use it to enhance our stroke programs. All right, so our next scenario is in preparation for a stroke recertification data tracer session. Your stroke coordinator would like to know what is the average NIH stroke scale for specifically the ICH patient population. So again, here's the workflow for the recommended steps, and Kim will go into the live environment to show you how to do that.
For this request, we're going to move out of configurable measure reports, and we're going to go into the time tracker report. This section of the tool historically was for what we call time tracker reports, calculated time treatment increment, but we've started to build out patient list reports and file them under this section as well. So you may see a new name for section of the tool coming soon. For this scenario here, I'm going to run some 2022 data. And under the stroke time tracker section, I can choose which columns or which data elements to include as columns in the report. So I want to have my total score of NIH and clinical diagnosis related to stroke. These elements here are in alpha order, so you can hopefully easily find the elements that you're looking for. And you do have the option in the time tracker report to choose your parameters, so you can run by discharge date, or you can run it by arrival date as well. You'll see what results here is a patient list, and it has the columns that I specified to be included. I can export this to Excel. Once the report is exported, I can filter for just my ICH patient. And then you'll see the total scores here. You can apply calculations if you want in column C, summarize the NIH scores among your intracerebral hemorrhage patients. Right, Sue, back to you for our next scenario.
Thanks, Kim. I love that we were able to share a demonstration of how to use the data tracker or the time tracker piece report that maybe typically you wouldn't turn to pull some of your important data. So our last and final scenario is, so the stroke physical and occupational therapists are interested in data outcomes for discharge disposition as well as discharge modified Rankin score for the ICH patients over the past 6 months. So their intent is to share this data and garner buy-in from their physiatry medical director as they propose to collect long-term functional outcomes at 90 days for this patient population. So again, the recommended steps are listed here as well as in your slide deck. So I'll turn it over to Kim for that demonstration.
For this scenario, we'll go back to configurable measure reports. Run our I'll run our 2023 data. And then under reporting measures, we'll select discharge disposition and MRS at discharge. We'll also add in that filter for final clinical diagnosis related to stroke. So we can filter down to patients with a final clinical diagnosis of ICH. Both of these measures are descriptive measures, both the discharge disposition and the MRS at discharge. You'll see we just have the descriptive measures tab, and we'll be able to toggle across both of those reports from the measures drop-down box. So for discharge disposition, we can look at just our ICH patients, and the measured details and case list will give us a table for the discharge disposition of the ICH patients. And we can toggle to MRS at discharge. And similarly, this will show us MRS at discharge among just ICH patients. We can also select ischemic stroke and ICH patients. And if you want to compare the MRS at discharge across those two diagnoses, you can do that as well. Okay, so back to you.
Great, thanks, Kim. We didn't put any scenarios together for the following considerations, but just wanted to start you thinking about how to use your Get with the Guidelines stroke data sort of outside of those configurable measure reports, which are wonderful, but there's lots of different options that you can utilize your data. So for instance, in the first report consideration, I just put here, identify how many patients receive anticoagulant reversal agents at an outside hospital. And then if you do track within your registry the hospitals that that are transferring to you, you can run a report on that. And then perhaps if feedback is needed, you have that information right there for you. You can also run baseline ICH severity score documentation by the single select provider. This could be a report card or a blinded report card, or just important piece for feedback if you are tracking that. If you identified who is your provider that is somewhat tapped to be responsible for completing that severity score. You could also use the data download report to run your patient data with ICH etiology and zip code and determine if there's any outreach need identified for community education. So again, from a hypertensive standpoint, if you know in a particular zip code area, it's most prevalent, that could be a really pointed focus for you. And then lastly, for consideration, just as an example, you could run your time to anticoagulation reversal plus the type of reversal agent that was given. So if you're looking at time parameters and you're seeing that there's delays, you would know by what agent that you're administering. Is there some process around that that could be developed? So again, just some thoughts to start thinking, if you haven't already, using your Get With the Guidelines data sort of in an out-of-box way. So, all right, let's take a turn. And I'm really happy that we've reached the point in our webinar that we have our model share participants. We will hear from all three of them. And at the conclusion of those presentations, we'll open it up for a panel discussion and then address any questions that you've entered in the chat specifically for our panelists. So first, we just have an AHA disclaimer here that the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only, and we do not constitute an endorsement or instruction by AHA ASA, and the AHA does not endorse any product or service. All right, with that out of the way, let's move on to our first panelist. We will hear from John Pham, a senior data analyst from Mass General Brigham and Women's Hospital. So John has worked in healthcare since he graduated from UMass Amherst and started out as a practice assistant in a migraine clinic and then as a sleep and seizure researcher before landing at the Stroke Center as a project manager. John will be sharing their ICH data dashboard as well as key indicators that they use during their team discussions. And hopefully this will garner some ideas, perhaps that you might want to utilize at your organization. So John, I'm going to turn it over to you.
Hi, thank you for the introduction. I'm happy to be here. We could get to that next slide, that'd be great. Awesome. So just a little bit about our hospital. So Brigham and Women's Hospital, we are a Mass General Brigham associated large academic medical center with a dedicated neuro ICU. Our volume is roughly 700 to 900 ischemic and hemorrhagic strokes per year. We provide telestroke resources to our community hospitals, and we are magnet recognized, which is the highest honor for nursing excellence. And next slide. So just a basic overview of the dashboard and kind of what went into creating it. First off, as far as the development goes, we have a few different dashboards that we utilize to disseminate our data to various leadership teams and members of our staff. We developed this using Excel and draw from both Get With the Guidelines for our data source as well as REDCap, which we use as our quality database. As far as key indicators go, we highlighted a few different things just to kind of give a overall sense of our ICH population. And of course, we included all of the new ICH layer measures, which is very exciting because obviously we haven't seen too much from it so far. So we're just trying to get a good sense of it and how it can help improve our hospital care. And for feedback, it's gone over well with our leadership team. I think the goal of it really is to just give everyone a sense of these measures, since again, they're new, and we're kind of learning about them still. And then also to look at our performance compared against other CSTK hospitals and see where we may fall short and need to work on some process improvement, and other areas where we excel, so we can give good feedback to our staff. And then I think this is where we'll go into the demonstration, right? Okay, is that coming through okay for you guys?
Yes, it is.
Okay, great. So our dashboard is broken into a few different sections. So like I had said, this is more so just an overview of our ICH patient population. Some of the key things we look at are always volume, just to see how things are progressing throughout the month as we get a lot of transfers, and obviously bed capacity is something that we focus on. So we want to make sure our volume stays relatively steady. Of course, we work heavily with neurosurgery, and they are always interested in seeing what kind of procedures they're doing, the volume of it, and how things are going there. This section here is something that we have emphasized as a bit of a process improvement project for us, focusing on making sure that patients in our ED, that they are meeting their blood pressure goal in a timely and safe manner. We took out some of this information here just as privacy concerns there. Finally, here we have just an overview of the stroke etiology for the ICH patients, broken down and just sorted by what's most occurring down to the least occurring here. In our next section, we have each of the measures laid out, and as a reference point, I follow the same format for essentially all of these graphs. The dark blue here is going to be our hospital and how we're doing in each measure, and compare it against the light blue, which is a benchmark that we run through Get With The Guidelines, which shows the compliance rate for all CSTK hospitals. So I won't go into each individual measure, but as you can see, what we try to do is familiarize everyone by including the description of each measure and how we're doing. This section is really meant to highlight any areas that we'd want to look deeper at. So this is more so a very high level glance of it. And for example, if one of our directors is curious and wants to know more about why we're only at 75% compliance for a severity score in January, what we would do is first take a look at what the actual N is for that month. So if we scroll over, we can see that we're 15 for 20 for that month. And then from there, we will look at those 5 patients who were not compliant in the measure and discuss them in detail when we meet, and kind of see what we can do to improve that. These here, this is something that we also would focus on as well. Our program manager, Danielle, she does a great job of going through each of these cases and flagging them, making sure that obviously this is just a standard measure and it gives you the minutes per time anticoagulant reversal, but obviously the context for the care is very important. So we just want to make sure that if patients are taking over 2 hours or so to get reversed, that there was like a good reason to do it. Lastly, this is where we will plan on adding in those 2 new measures that Susan had mentioned earlier. And we are in the process of just abstracting all that data and making sure that everything is inputted into Get With The Guidelines accurately. And this is just as a quick look. This is the structure that we put in for the data. So we update this on a monthly basis and it gets refreshed in the dashboard. But that's really all I have to say about this. I'm sure if there are questions, that would be great after, but that is our general dashboard for the ICH layer.
Thank you so much, John, for sharing your template and also the transparency of your data and how you're sharing your data. I'm sure we'll have some great questions for you after our panelists have concluded. So thanks, John. So next, thank you. So next, we're going to hear from our second panelist. So that is Kathy Schmidt. She's a stroke data specialist at the Hospital of University of Penn. Pennsylvania, excuse me. And Kathy's been a neuroscience nurse for 35 plus years. She's functioned in roles of staff neuroscience nurse, educator, and stroke coordinator. She's currently working as a stroke data analyst. So today, Kathy's going to share some strategies that they've utilized at their organization for improving documentation of ICH baseline severity scores. So Kathy, I will hand it over to you.
Thank you. Hello everyone. It's great to be here, and I'm happy to share our challenges and our successes with you today. Next slide, please. So we are the first department of neurology in the United States. We like to boast that we're the first CSC and one of the first 10 CSCs in the United States in Philadelphia. We have 2 downtown academic hospitals, and we care for about greater than 1,000 strokes per year, roughly 980 beds in our facility. Next slide, please. So we're a major tertiary care center in Greater Philadelphia with 14,000 strokes per year in the region. About 2,000 stroke team calls per year, and that could be anything from acute care advice, transfers, and we do telestroke to Penn Medicine Network and beyond. Next slide, please. This is just a quick picture of our stroke team here on top of our new helipad in Philadelphia. You can set next one. So we saw consistent fallouts and poor compliance with our ICH and Hunt and Hess scores. Hunt and Hess being for subarachnoid hemorrhage, which is pretty most CSCs deal with. So we used the same strategy that we used to improve our Hunt and Hess scores, which was easier because we were dealing with the neurosurgery service, whereas with ICH scores, we're dealing with several different admitting services. So, our problems were directly related to role expectations, responsibilities, and admitting service. So as an academic center, rotation of providers creates challenges, of course, and in PSCs, it probably is more of a challenge having to do with neurology or neurosurgery being a consulting service, whereas we admit directly to neurosurgery or to neurology or to neurocritical care. So we saw some opportunities in our arrival modes, from whether they were transfers or whether they came into our ED. We looked at all of that. Explaining the why to all of our providers, in the different services was monumental for them to understand why this was so important that we collect our ICH scores and have in a timely manner. And accountability was essential. So we made people accountable by sharing our scores with, sharing our data with them to see where we were falling out. Next slide, please. So how did we implement this? Well, we locally, between the stroke and the neurocritical care team, the ED team, and the tireless effort of Colin Hoey, our stroke coordinator, and now assistant director of our stroke program, to monitor compliance and provide support and education to our providers. So it took about 4 weeks, including the EMR optimizations, which everyone knows that takes time. We had a doctor as a builder on our stroke team, assisted with the navigator build, and I'll go on in further slides to talk about the navigator, and dot phrase creation. So next slide, please. So this is just a quick slide to show our pre-intervention data. So I'm looking at 2002 Q3, 65.6% for the CSTK 3B measure, which is CSC, CSC measure. So next slide, please. So after we, okay, next slide. Thanks, Gino. So in 2023, you can see the, much better, 91.3% after all of our interventions of education and, utilizing everything, speaking with all of our physicians and our teams. So next slide, please. Just a quick multi-year analysis, just to highlight, and you would hit when you see 50%, we don't get too upset about that, because a lot of times it has to do with numbers. So if you only have 2 patients and you have 1 fallout, it's gonna be 50%. So, we're very pleased, toward the end of the, in 2023, in July, August, and September, we're seeing great improvement in our scores. Next slide, please. It's just a quick comparison between the AHA stroke 158 versus the CSTK3B, which we collect both. And just as a little caveat, we've been collecting ICH data at Penn since 2003. We've always included our ICH patients in all of our data collection. So it's not new to us. We've been collecting it for a long time. So the AHA 158 is the severity score based on timing of up to 6 hours of arrival or prior to any intervention or surgery. We recognized that patients that did not have a last known well recorded, and that had to be date and time, were excluded from this measure, as opposed to the CSTK measure 3B, which is just the ICH score. The exclusions for that would be comfort measures. If they were, had comfort measures as of day one, they'd be excluded from that measure. So hence the differences that you see. It's not great differences, but there is difference in the percentages. Next slide, please. So we incorporated the successes we had from the H&H Hutton Hess scoring for subarachnoid hemorrhage and applied it to our ICH population. So we looked at how we spoke with the providers and how we implemented that to better our H&H scores and use the same strategy with ICH. So we formulated a stroke navigator template that houses all the scores and interventions. So it's a one-stop shop. So, and later slide, I'll show you what that looks like. This has been great because, all the providers know to go right to that stroke navigator and to plug in, so the first provider that sees the patient plugs in those scores. So we created a unique dot phrase to pull in the score from the stroke navigator. So it could be streamlined by the, came into the, the clinicians had them in their notes to make it a lot easier for them. Constant feedback and monitoring included, and so we would include in our monthly stroke meetings at our neuro ICU, M&M, hot topics. We would definitely include all of our data, any fallouts and this and that in our stroke meetings. We assessed various arrival modes for fallout analysis. So looking at whether we had more fallouts from people being transferred in or from our ED. So we looked at all of that. Demonstrated score completion and dot phrase utilization, and incorporated the voice of the customer. So we listened to our providers and what their challenges were, and we worked together to make this happen. So next slide, please. So in terms of sole group responsible for severity scoring, that was very challenging. We had a lot of pushback with that. Okay, who's going to do this? Is the resident going to do it? Is the fellow going to do it? Who is going to be responsible for that? So, they came to, they decided who was going to be responsible for scoring and the navigator, and then so the accountability comes in there. So the constant rotation of new providers, makes that difficult. So, and patients can arrive in, different ways through the ED or through outside hospital transfer. So we had to look at all of those things. So we bin the scoring based on discipline. So we look at each discipline and see, what our success was in scoring and our percentages. And we utilize physicians in the vice chair of quality for support in that. So we have a new QI project proposed by the neurocritical care folks, which now hinges on the ICH score completion for length of stay initiatives, which is a really big initiative. So now it's become, important for a different reason, that they want to know what those scores are, so we can use that in our length of stay initiative. Next slide, please. So next slide, thank you. So this is just a snapshot of our stroke navigator. Which is inclusive of, we put our thrombectomy times in there, we put the NIH stroke scale is in there, anything that is, this is on the patient arrival, right from the stroke alert. Next slide, please. So this also includes our ICH scores, and okay, this is the Hemorrhagic Stroke Scale score. So if you go to the next slide, you'll see our ICH scores in there too, and the arrow shows how it incorporates, it goes into their template, in their notes. So it's easy for them to follow. So next slide. So lessons learned, communication is paramount. Well, communication is, as we know, is paramount in everything that we do. So it definitely makes a difference to be communicating to our providers, explaining the why, and explaining to them why we're doing this. When people understand why you're doing something, they're more apt to be compliant. So determine the responsible group from the start, which is what we try to do. Provide boot camps prior to new staff starting to avoid July fallouts. We all know what happens in July. So we have to make sure that everybody's on board so that we don't have fallouts in July and August. Structure process applicable to multiple domains and metrics, and leverage the EMR to streamline. So, and physician support is paramount also. Next slide. So assessing length of stay opportunities for the ICH patients. Okay, so these are the next steps that we're taking with improving our ICH scores. Hinges on, because our length of stay hinges on the severity score documentation. It hinges on the severity. So hinges on severity score documentation to group in patients. So we try to, we're looking at each group that would be scoring patients to see who is compliant, who is, where we're having challenges. Creating specialized pathways based on severity score. So we're looking at patients who have lower scores as opposed to higher scores, and trying to specialize pathway for their hospitalization according to that. Recent success of expanding early supported discharge to low ICA score patients. So trying to make sure our low ICH score patients who are doing well, are discharged in a timely manner. So we were able, through that, through looking at that, we were able to decrease our length of stay by 1.5 days. So, and lower readmission rates with our lower score patients. Analyzing opportunities for various services that for higher scores, like looking at our scores as opposed to looking at our lower scores and higher scores, and when are not, sorry, when a PEG, looking at whether a patient's going to need a PEG tube and whether we're addressing that, in a timely manner. So next slide. So I'll wait for your questions later, and I left our email addresses. Colin is our assistant director and our stroke program coordinator, and he's happy to answer any questions as well as I would. Thank you.
Thank you so much, Kathy. I really enjoyed that presentation. I loved how your focus on one quality improvement measure really is lending itself to expanding your quality in different areas. So love that example. Thank you. All right. So we're going to move on to our third panelist, and that is Linda Matrich. Linda is a quality assurance manager at the Milwaukee County Office of Emergency Management, the EMS division. So Linda has served in the role of quality manager for the past 6 years. And prior to that, she worked at the Medical College of Wisconsin as a certified clinical research coordinator. And finally, Linda was a lieutenant with the Milwaukee Fire Department for 33 years prior to that. So Linda's going to address documentation quality improvements from the EMS perspective. As we know, last known well can be documented by our EMS providers, as well as our outside hospitals, as well as those patients who arrive at our front doors. So last known well documentation for ICH patients lags behind that of ischemic stroke. That bore out in our phase 1 of our initiative. So we found that up to 50% missingness of last known well documentation was evident for our ICH patient populations. So our goal is really to learn from one perspective of documentation around last known well, of how EMS has really implemented in outstanding quality improvement within Milwaukee County. So with that, I will turn it over to you, Linda.
Thank you very much, Sue. It's a pleasure to be here and to share some of the great things that our agencies are doing in Milwaukee. Next slide, please. So just a little background on our system. Milwaukee County EMS is a collective of 15 agencies, which includes all of our fire departments and county EMS working together to provide great patient care. We work under the medical direction of the Medical College of Wisconsin to provide administrative support and oversight of our EMS system. That includes things like educational content, operational policies and guidelines, quality assurance, controlled substance management, communications, etc. We work very hard to ensure very high quality patient care with a focus on equity, compassion, and innovation. And we really work to include equity in all our projects and outcomes. We work hard to capture accurate data. We have a dedicated data team, and we hope to leverage that data to improve systems and further inform our public about health and safety measures. Similar to a slide that Sue shared early on, determining if there's an outreach needed by zip code or census tract, that really gives us a good overview of where we can target some of our public education down the road. Next slide, please. So our QA team itself, we have 3 dedicated members. All of us work very closely with our hospital partners as well. We have data sharing with our agencies, EMS providers, and hospital partners. As the manager, I oversee quality improvement, case reviews, KPIs, our key performance indicators review, and our feedback processes. And my partners that work with me have roles working directly with our hospital partners. Others work directly with our fire departments. And of course, just like many agencies, all our roles overlap. We have a monthly meeting, quality meeting, with our fire department and county agency partners to review system issues and case reviews. Every single case review that comes into us, we review as a group, so everybody is aware of any issues that are ongoing. In our system performance section, stroke performance is one of our main system topics that we discuss every month. We review each and every stroke KPI. We talk about our case reviews. I'll talk a little more about looking at our missed stroke alerts and our stroke improvement project. When we do our case reviews, we provide feedback directly to our providers after the review. There's comments and input from our quality team and our medical directors. And again, this goes directly to our providers. And since we review missed stroke cases, for instance, our providers get feedback on those as well. Our system uses a just culture approach to our reviews. We've worked really hard to develop a culture of patient safety, which is really critical within EMS system. We embrace the concept of shared accountability, and we recognize that human errors are opportunities for us to learn and improve as an organization. And we do this in a non-punitive environment. And really what it gets down to is this is about a culture of learning and shared responsibility. And that takes time to build. It's definitely not an overnight transition. Next slide, please. So we switched from using the Cincinnati Stroke Scale to BFAST, which includes balance and vision onto the FAST scale, and LVO in 2018. This was a collaboration between our systems and medical director, and I mean systems like the hospital systems as well, to align with best practice for emergency stroke care. Now this was a big switch for us. We did not have a focus on large vessel occlusion before that, and we created and added a screening tool for our providers to utilize while on a call. So we had to create education for our field providers, We included this in an annual round of updates that we do. We incorporated it into simulations. And we also had subject matter experts from our hospital systems come and do live presentations to our providers. And then along with these changes, monthly at our CQUIT meetings, we would discuss the changes and the incorporation of our monthly KPI metric reviews. Right in our document for stroke, our practice guideline, these are 3 goals that are right in our document. We wanted to identify patients with stroke symptoms, especially with LVO symptoms, transport those patients to the most appropriate stroke center based on the additional LVO screen, and we wanted that code stroke, that early pre-alert, to include the LVO status. Now, this was asking a lot more of our providers in assessment and choosing various destinations. We also, we're highlighting new therapies like thrombectomy for our providers, things that, can be done at the hospitals, and that really helped get buy-in from those providers with better performance treating stroke patients. Looking at our last known well time evolution via our code stroke, which is the early alert we send to hospitals. Back in 2013, we used last known well within 8 hours and a positive Cincinnati stroke scale as our criteria to send that pre-alert. By 2018, the last known well time had expanded to within 24 hours, and we had incorporated BFAST for our initial stroke scale, and then also the additional LVO plus positive or negative. And then we also, in our guideline, designated hospitals as either primary stroke center or comprehensive or thrombectomy capable. And then looking at 2020, we took that last known well time and we added into our documents and training that we wanted last known well military time format to be mandatory, obtaining that, having our providers do that. Next page, please. So now we made it mandatory because just because we say it's going to be, how does that happen? Well, last known well time still remained poorly documented, sometimes only mentioned in the narrative, sometimes broadly written as a duration, etc., and often confused with discovery time. We, on the data side and QA side, we had to scour the record to find that information. Basically, we did not have a standardized reporting of last known well. So back in 2019, we started that discussion about using last known well military time to try to identify what the barriers might be to incorporating this. And we even talked to our providers in some of our case review meetings, which we call PIRs, post-incident reviews. They're just brief 10, 15-minute discussions. We'd ask providers about that too. So we were gathering feedback before we put it into some of our documents in 2020. Recognizing we needed to continue education on this topic, we really tried to drive home education about the importance of an accurate last known well, recognizing how important that is on the hospital side too. And, our providers have that first exchange with the patient or family that can set everything in motion. So we really wanted to stress the importance of accurate last known well. So again, woven into education, quarterly education, simulations, etc., with continued discussion. And then one important point is for our providers in doing a stroke assessment, we don't distinguish between you do it this way for hemorrhagic, that way for ischemic, etc. It's the same scale, the same process. We're expecting our providers to do it for all these patients every time. The EMS communicators, which in our system, our providers don't necessarily call a hospital directly. We go through a communicator, and they are so key in creating that pre-alert. Our EMS communicators, we educated them, and they would prompt our providers to provide that last known well in a military time instead of elapsed time. So they started getting used to reporting it. They needed to report it. They were asked to do it during their report. So that kind of started the expectation to report this and know that it was important. If they were asked for that every time they had a stroke alert, they're like, well, you know, then we just need to be in the habit of obtaining that accurately. Along with that, with those early pre-alerts that we send, we cleaned them up a little bit. We wanted to make it brief, easy, encouraging that pre-alert as soon as that stroke exam was positive. So we had, earlier on, we had vital signs listed in our pre-alert. We took vital signs out and we put last known well military time in. And that did two things. Again, it prompted our providers to know that this was important and to get that information early. And it also was a check by our communicators that it was actually within 24 hours. And this was key in moving that compliance with getting that forward. And then eventually we made that a mandatory item in the electronic patient care record where they're putting information in on the scene or at the hospital. It had to be put in military time for when stroke was the working assessment. And then eventually we added it to altered mental status as well. So they couldn't finally submit that report without putting in the last known well time in military time. So this was one of the barriers that I'll talk about as well. We didn't have one single platform at the time where we could go in and just make it mandatory. We had to work through all of the 15 agencies and their vendors to try to put this in place. So we had groups, we had about 6 different groups. And in some of those groups, the fire department had control over that setting, and in others they didn't. So it was a process to get everybody on board with this. Then we looked at all the language in our documents, like our policies and guidelines, our practical skill sheets, training, etc. And we tried to make sure that even we were consistent in how we talked about it, that we always referred to it as last known well military time. So, and we continue to do that today. This took a while, you know, we are a large system. We have upwards of 1,500 providers, and this is it takes a long time to get everybody on board with not just hearing it once, but implementing it in practice, repeating it, and getting good at it. So I put down, you know, 2 to 3 years, but it's really ongoing in our system. Next slide, please. Where we are today, over on the right, you can kind of see a small example of a dashboard that we use. We created an internal stroke dashboard to help look at our monthly performance and trends. And also this lets our agencies go in there on their own and see how their own providers are doing. Also, this really gives us a great way to look at this data through an equity lens. And again, our county and our division and our EMS group, we are very committed to equity across our county and for our patients, and having a nice dashboard that we can really drill down to age, gender, race, etc., and outcomes. And this is really great. So what we're working to do right now is evolve this to a public-facing dashboard. Now, we've done this with a cardiac arrest dashboard, and we recently just published that, and I'll have Sue put that in the link so you can see an example of what our public-facing cardiac arrest dashboard looks like. But we've had a discussion with all of our hospital providers and our agencies, and we're working for a public-facing stroke dashboard too. And this would be huge, a great way for our citizens to see, you know, how we're performing, where areas of need are, and we can have links to education for anybody viewing this that will hopefully be very valuable and improve our outcomes. We continue to discuss stroke monthly. We've been in the middle of a stroke improvement project, we call it, that we've been doing for a couple years now. One of the things that we added to that is reviewing missed strokes, which we didn't know what we didn't know, right? We're great at looking at the cases where our providers did the alert, but what about the cases that we missed? So thanks to our stroke coordinators at our hospitals, we've asked them to inform us when we have a missed stroke, and we enter that through our quality process. And we hope that it not only is an opportunity for learning for the providers on that call, but it helps us as a system to learn why we're missing these and how we can address that with education, review, etc. I mentioned earlier the challenge of getting everybody on board with the last known well in their EPCR. Well, now we are in the process of moving everybody onto one bridge. About half of our units on, the other ones are in the process, and now we'll have a consistent reporting of this data for our entire system, all reported in the same way. That's been a huge project. Down on the bottom, one of the big changes or big outcomes from this is back, 7, 8 years ago, even as early as maybe 5 years ago, we were reviewing 40 stroke alerts per month across our system. Now we average 110 strokes per month. Now we added, the BFAST and LVO, like we're catching way more strokes with the addition of the B for balance and E for vision. And our providers are just becoming much more aware of stroke symptoms and LVO symptoms. And before, when we were having those 40 alerts and say 20 of those were positive confirmed strokes, now we're doing about 55 a month. So we're catching way more strokes, our providers are, which is fantastic in terms of, outcomes and, returning to a normal life, et cetera, and having the best possible outcome for your case. So I think that's a great outcome for our system and for our citizens. Next slide. We've been participating in Mission Lifeline since it started. We love that the stroke criteria is included now, and it really bonds partnerships between EMS and our hospitals. And our agencies are proud to display this certificate at their departments, showing the high standard of care they provide to our patients. Next slide. I did talk about, some of these challenges already, and just to highlight, it is a challenge getting 1,500 or so providers educated on the importance of it, but it just has to be done. And that's a long process for us, but we really, really need to get providers to understand how important the last known well time is for patient care and procedures that follow, after ED arrival. One of the challenges that we ran into was, altered mental status patients, and some of this we learned from our missed strokes. And our doctors went in and tweaked our BFAST LVO and provided more education on how to handle patients that aren't completely oriented, and so that's been very helpful. Some of the current discussion we're doing is promoting that early pre-alert by that first company on scene. So our goal is really to empower our providers with confidence in assessing and reporting early, not necessarily waiting until the transport unit gets there. And I already talked about our missing stroke reviews. We've been doing that for over a year, and that's been some great insight that we've gained, and we're continuing with that project. Next slide, please. So some of our successes, we have nearly 100% reporting of last known well time, much more standardized process now. This unified EPCR is going to help with that as well. We are capturing way more strokes and even identifying LVO strokes. We have our dashboard that is soon to be public facing, and tie in with public education and community outreach. And hopefully, we can help the public to become more efficient with their own stroke recognition, just like our EMS providers and hospitals have. What will we do different next time? Perhaps more education to our providers for that upcoming big change we had in 2018. That takes quite a while to be absorbed and completed by a big group of providers. Thinking back, we could have made the last known well military time mandatory in our earlier on, say alongside our guideline change, and that's something we'll remember for the future. And with our providers, just focusing more on them knowing the importance of an action, right? That last Noel, and examples of the importance of that education, you know, and how that contributes to the best outcome for our patient. And then even more hospital partners asking them to be content experts in delivering some of our education. That was really well received by our providers. So they, you know, enjoyed having someone that they will occasionally see in the ED provide some of that content for education. Well, thank you very much. I look forward to any questions that follow.
Thank you so much, Linda. That's amazing, comprehensive approach to your quality improvement, and just the vast number of providers that you had to educate, and not only needing to partner with all of those hospitals for that feedback. It's just outstanding example. Thank you again for sharing that. All right. So now this will bring us to, we have about 12 minutes left to our webinar time, and let's have some discussion for our panelists. So Kim or Jason, if we could launch any questions that are specific to our model share that you're seeing in the chat, that would be terrific if we could address those now. I'll just start out with a general comment. As all of you were speaking, what kept coming to mind was communication, communication, communication. Having the right people at the table, having the right stakeholders, having the right buy-in. That, you know, quality improvement, that's, I feel like, such a high priority for the success of quality improvement. So this can go to anyone. How do you navigate that communication process up and down, perhaps your hospital? You know, for instance, John, when you share your dashboard or want to communicate your stroke outcomes, what does that look like within your organization? How do you move that data so all the important players are aware of how your hospital is performing? Was I on mute during that time?
No, sorry, I was muted there.
Oh, okay. Sorry, John.
No worries. So for our dashboard, we actually host it on SharePoint, and the link is distributed, so anyone can access it at any time. We typically do schedule meetings either monthly or quarterly, just to go into more depth and really dissect the data and see, you know, what, you know, our directors or physicians are more curious about. But I would say, I mean, just as far as I think we do a good job just being available for questions. So we are, as a team, pretty open to, you know, hopping on calls or kind of being flexible with our schedules as far as communication goes, so that we just make it very pointed that, you know, we're here to support and available for any questions or anything like that at any time.
Thanks, John. I'm sure that's when your recertification comes along, that's a wonderful example to share with your surveyor too, how you really communicate this as an ongoing process. So really well done, thank you. All right, I'll pivot over to Kim if there's any questions that you see.
Thanks, Sue. First, I'll just mention that we're getting lots of comments in the chat that these presentations have been really fantastic. So I just want to thank all of our presenters for that. And then for our presenters too, if you're willing and able to put your contact information, if you want to share it in the chat. We have a couple users asking if they can connect with some of you on some follow-up questions. We do have one for UPenn asking if the navigator dot phrase, it sounds like you're using Epic as your EMR. Could you clarify?
I'm sorry, was that question for me?
Yeah, I'm sorry,
Or in
Kathy.
hospital?
It sounded like the navigator dot phrase sounded like Epic language. Could you confirm if Epic is your EMR you're using?
That was for Kathy.
Okay, it just unmuted me. Sorry, I was muted by the organizer. So
Oh, no. Sorry,
I don't
Kathy.
blame you for that. I'm just kidding. So the question was, do we use Epic? Was that the question?
Yeah.
Yes, we use
Exactly.
Epic. Is our platform.
Okay, and then the next question is for you as well. They're wondering, how is the ICH score collected? Is the score free text in a note and manually needs to be pulled out? Or is it a unique entry in the EHR?
No, we
Just a
pull
little
it
bit
out.
more information how to-
I mean, we have a unique circumstance in that Myra Pressman, the other data analyst, and I, we sit right with the doctors and with everyone in the on the stroke team. So we pull that data out of the chart. It's like I said, from the navigator, it's pulled into the physician's note in the template. So we pull it off the template of the first, or it's right in the navigator with the date and time. So we're able to look at that in Epic, the navigator.
Great, thank you, Kathy.
I don't know if that answers the question or not, but
yeah, there were actually a couple about whether it was discrete fields and how you captured that.
yeah, it doesn't pull directly into Get With The Guidelines. We haven't. We abstract that and put it into Get With The Guidelines.
Great, thanks, Kathy. We have a question for John. For your dashboard, we got a lot of really positive comments about that. Is this specific to ICH, or do you have very similar dashboards for other measures like STK and CSTK?
We visualize the data in a few different ways. We definitely do have dashboards for the other stroke diagnoses. As far as the STK and CSTK measures go, we send that out monthly in a PowerPoint presentation. But we do utilize dashboards in a very similar format for things like transfers, access, and other things like that.
Thanks, John. And then we have a question relating to the EMS initiative. Can you share how you got buy-in with EMS to use BFAST? So just any information about how you collaborated with the EMS agencies for this initiative.
So that started out as a collaboration on the higher side with our medical director and the systems. And then I think the point of catching more strokes, like EMS has the, I'll call it a privilege of identifying that early and directly affecting the patient's outcome by having this information. So I think we approached it from EMS being in a unique position to not only use this additional scale to identify more stroke patients, which we can show they've done, but they are in that unique position to do that early, report it to the hospital early, and getting them to the right hospital, especially for like these LVO patients. Once they saw the cool things that were being done, like thrombectomy, like showing them that process, I think that really helped get buy-in.
Great, thank you. And we also have a comment here, if you're willing to share the link for public reporting site. It looks like somebody put it in the chat, but there was a request for that as well.
I have a question. This is for Linda. Linda, how did you get, again, it's going back to the buy-in from the hospitals to report back to you, with those misses?
Oh,
or
yes.
did you work with the stroke coordinator, the EMS liaison? It's just amazing that they wanted to collaborate. That really speaks to your hospitals in your county.
Yeah, absolutely. And I will say my partner, Bill, that works mostly with those hospitals, has cultivated, maintained those relationships for years, at least, for the last, since 2015. Both sides have been very accessible to each other. If our hospital stroke coordinator, say they're having a commission come in and they're working towards certification, we go to that certification and we provide that EMS perspective that they need in that meeting. If we want to share outcomes with providers, our hospital stroke partners will, some have made posters even and t-shirts that they would ask us to distribute to a unit that say had a remarkable, door to needle time or whatever. We are both invested in a high standard of care. We're all of us are in Mission Lifeline as well. So we definitely need each other's data. And we also have, I would say, a really high respect for each other and our parts in that process. So I think it's just been having that quality person in the same position for a few years has been hugely valuable. Just building those relationships and maintaining them, being very accessible for each other, and sharing outcomes together.
That just speaks volumes to your organization, Linda. Thank you for sharing that. Kim, do we have time for one more question?
Yeah, I was actually have a pretty quick one, I think, here for Kathy. Which discipline did your site tie to be initially accountable to document the score into your newly developed Navigator tool?
So this was kind of the problem that we had, that we are still working on. We want the admitting provider, whoever the admitting provider, whether that be neurosurgery or neurocritical care, so or neurology. So we have assigned groups within all of those disciplines, whoever is admitting the patient. Each of those disciplines has an assigned group that is to document the initial ICH score.
Great, thank you.
Thank you, Kim. I think we'll end it there. Thank you again to all our presenters today for really sharing your time and expertise as we learned more about how you operationalize quality improvement for your stroke patients in your communities. And thank you to everyone for attending. Once you leave today's webinar, you'll receive an email with a short survey. We'd love if you would complete that to provide feedback to us. Within 24 to 48 hours, you'll receive a follow-up email with this recording. And also you can make sure you download the handouts, the PowerPoint slide deck for your reference in the future. So on behalf of the American Heart Association and our presenters today, thank you so much for your attention and have a great weekend. This concludes our presentation. Bye, everyone.